So we move on to the next session, and the next session is indices, way to indices, and we have a speaker, Mr. Siva, the product manager, quality and Biorad Laboratories. Warm welcome to you, sir. May I request you, sir? May I request you kind
Thank you, ma'am. Thank you, Dr. Geeta. Thanks to Kahukan. Thanks to organizing chairman, Dr. Shivin sir. Good evening, one and all. Today's topic, so I'm going to talk about way to deal with HIL, which is hemolysis icterus and lipemia. Then we will talk about something called serum indices product. And in total objective of today's talk to talk about serum indices, and before that impact of pre-analytical errors and recommended setup for serum indices, how serum indices works and what serum indices actually meant, and then what are the advantages for interlaboratory comparison if at all participating in a unity interlaboratory comparison program. Then what are the different regulations it speaks about and the recommendations that provide. So we all know that the most common pre-analytical errors we receive from the pre-analytical area. And again, from the pre-analytical, so mostly we hear from hemolysis is the one bothering area. And then incorrect patient identification, of course, then insufficient sample volume and clotted specimens. So these are the things that we see basically from the pre-analytical errors. And just to add to that, do we know we have around 21 plus pre-analytical variables outside the laboratory, before you get the sample into the laboratory, before you get it into the examination phase that are affecting the sample's integrity. And of course, also we have 16 additional variables that are within the laboratory once you receive the sample. So just a study that around 70% of the specimen quality related issues that are associated with hemolysis. Okay. Normally, we know that around 60 to 70% of the issues or errors that normally occurs at pre-analytical phase itself. Even from that pre-analytical, 70% of the errors from the hemolysis itself. Okay. And then just look at one of the scenario. There is one 40 years old female who is an insulin dependent diabetic patient. She visits outpatient clinic for the routine monitoring, and lab reported the elevated concentrations for the potassium, and sample was hemolyzed. What could have been the impact? The low impact was that if the lab was able to understand that there was an error, and they understood and they have taken a corrective action and they rejected the test, patient goes off, and of course they have requested the patient to come another day, right? So that's the lowest impact which can happen. When it comes to the medium impact, the lab did not detect the error. There was an error, and it's elevated concentration values which is provided. And then the patient is sent to ER, emergency room, to be treated and eventually discharged after certain makeups done. That's a medium impact, maybe a temporary discomfort, but however, that had happened to the patient, which is not necessary. Then comes to the critical impact, what it could have been. So the lab rejected the specimen, right? The patient isn't notified for a redraw, and the patient's condition worsened, and her condition becomes critical, including sending to the emergency room and doing all other major workups. So this situation can happen in any laboratory, anywhere, anytime, point in time, right? So considering that, or maybe just considering as one of that, so we understood that poor specimen quality definitely affects an average pre-analytical errors cost. If we have looked at a study that is done in North America, which is giving around $162 per patient for an inpatient, and for around $337 per outpatient it is costing. And for a 650 bedded hospital, if we take approximately 1.2 million per year, which is it's a huge. So this is included everything, apart from the pre-analytical area, including the cost that are associated with the redraw of sample and consumables, lab investigation, further instrument downtimes, etc. And of course, patient treatment, all of that considered, it's a huge. Then the most common errors as we talk, are you actively addressing the most common pre-analytical errors when it comes to the addressing the pre-analytical errors? So we know that, what are pre-analytical errors? I don't have to explain this much. So HIL is there, right? However, the integrity of a patient sample in the pre-analytical phase, as it plays a very key role. We also know that, and we also have today's scenario, we have the equipments from various vendors and the manufacturers that are coming with included automatic HIL detection procedures or automatic HIL detection features, right? So most of the times we may switch off or we may switch on. But it is ideal to switch on as a HIL mode. And normally this HIL mode works in a way that, it looks at each sample and try to analyze through a spectrophotometric detection if the sample has any kind of interferences in terms of HIL. Okay. So we know that the laboratories are faced with majority of issues, while taking the decisions in terms of sample integrity, right? That could potentially impact the patient. That can lead to further investigation also. However, how confident are you that the instrument is reporting the correct interference value? It means the HIL which is functional, how good is that HIL index itself, and how confident you are depending on that result. Why was this question have come? So when you have so much sophisticated and advanced, latest cutting edge technology kind of equipments that you have, and that are provided along with HIL detection solutions, then why was this question comes? Now the question comes because the problem is that HIL workstation is also subjected to get drift, and also it is subjected to get fail, right? So when it comes to the failure, what it could be? The failure could be towards maintain the consistency of that HIL module functioning, okay, and the interference of workstation over time when it is running, and when you turn it on, and when it is running like a 24 hours laboratory, that can lead to the changes. So it can affect the efficiency of the particular HIL module itself, and that can fail also at times, right? So it's an estimated around 45K instruments worldwide utilizing this automated interference detection workstation that detects and calculates the HIL. This is just a normal survey. And today the lab fully relies on manufacturers of analytical testing systems to assess the hemolysis index, as we know. Manufacturer details when to reject the specimen because of the interference. That includes that induced bias, but do we trust that the instrument performing the HIL test always correct? We are not sure. So the manufacturer usually does not provide the performance characteristics. The performance characteristics means like in a regular QC practice where you look at for an imprecision and bias and sensitivity and specificity. These performance characteristics, normally you won't get it through the just a HIL module, which is just turned on in the instrument. Now, do they provide any appropriate control material also to ensure the performance is as expected and it is accepted to run the patient samples? And as we know that interferences that can be, what all can be through the different phenomena, so be it a hemolysis or be it icterus or be it lipemia. We know that there are a set of analytes that can interfere, that can contain the bias, and this bias, as it is added to your analytical phase bias, that normally the system tend to get deviated from the acceptable performance criteria. It's like, it can be double also, or it can be more than that, right? So there is that possible addition of the bias, which can further add to your total error calculations, if at all the lab is used to practice, or be it the analytical quality goals that you have set, whatever, it may become like a hurdle to achieve that. Okay, so in order to mitigate that, what is the best system that we have? So Biorad brings us a solution for that. We have a product called Liquid Check Serum Indices. This resembles the patient sample, like it comes with a human-based matrix. It's a kind of a replicate of relevant concentrations if you take HIL. That means for hemolysis, for icterus, and for lipemia. For all of that, it has that relevant concentrations, which is replicating exactly the patient samples. So by having this and by running this before running the patient sample, so it will provide that working as an effective mechanism, an effective quality control system, so that when you run these samples, your system, how good is that detecting at interfered samples? As we know, the patient samples normally we consider as a blind samples, right? So we have nothing to refer to the patient samples until or unless you really see, or if you are not analyzing through the naked eye, right? So when you have this kind of a product, so when it has that explained phenomena already in each sample with an interference, it definitely try to evaluate and test the HIL module itself, which is there in the instrument, so that it identifies the potential drift or any failure is there in the HIL system. Then also we have the large number of users across the globe. So by having this and you start reporting the results, putting into the QC data management software, like we have Unity real time, you can just use them as different level of control product, and then you can also get compared with the across the globe participants, so that not that HIL module that you use in the laboratory and you are trying to evaluate its efficiency and you are trying to understand its drift and failure situations, but also you are getting comparing with the worldwide peer participants. Okay. So with that, I just wanted to explain through this one particular slide that Bio-Rad has that complete solutions for pre-analytical, analytical, and as well as post-analytical, as we have informatic solutions like QC data management software we have, and connectivity solutions also we have. So with this particular pre-analytical mode, we become like a complete QC solution provider. I just wanted to say. And then if you look at these are the order information. So these are the product it available in the package, like 6 into 4 ml of each one, or 1 into 4 ml, both are available. And how to configure this product and how to use this particular product. So configuring this product, especially when it comes to be it in your analytical testing system or be it Unity real-time software also, normally we consider all these 3 interferences, HIL, and also we have one more called non-interfered, which is considered to be as a normal specimen, normal human specimen. Okay, so you have 3 phenomena, both hemolysis, icterus, and lipemia. You can test and you can look for the results that is expected from each phenomena. Is it meeting or not? So that way we are evaluating your HIL index module itself. Okay, this also can be configured both as a qualitative and quantitative. That depends on the manufacturer's and output. What is the output that you get from the manufacturer system that you have? And then you can also run this appropriately for a positive level. And as I said, the 4th one is a non-interfered. And these are the IFUs. Maybe you can refer in later, or I can share, or maybe my team across the India. We have local representatives also. You can talk to any one of them, so they'll be able to provide these IFUs. You can look at each of the phenomena and what IFUs talks about. And of course, we have the target and reference ranges also for each phenomena. And then the very interesting thing, as I have spoken about, how to use this and how to set up this. Especially for that, we have a couple of important papers here. One is EFLM guideline. There is a local quality assurance of serum or plasma, especially dealing with HIL indices. There is these recommendations from the EFLM guide, group of people. This article I can share later. So I'll take you through that particular guidelines of what it is talking about and how we can set up the HIL in the laboratory. Then comes to the peer-reviewed scientific article. There is another article in which it is detailedly discussed about evaluation and operationalization of the commercial serum indices quality control material in the clinical laboratory. Okay. So through this EFLM guideline, so what they try to explain is that the appropriate detection and management of a serum indices that requires adequate both internal quality control as well as external quality control. It also explains about monitoring day-to-day variations of HIL indices. Should it become as an essential part of a daily routine? If so, how laboratories needs to adapt this process and how to get that evaluated when comparing with the worldwide peer group. So all that was there. And there is a set of recommendations one by one. Let me just take you through. Let me read out for your easy understanding.
Sir, sorry to interrupt. We have 1 more minute left. Thank you.
Yeah, thank you, ma'am. Thank you. So IQC testing should be always performed for validating performance of HIL indices in routine and urgent conditions also. And IQC should be performed at least 2 times per day according to local regulations and protocols. The former assessment should be ideally performed before starting the patient samples after maybe 8 hours or 12 hours of the later work hours. Then IQC should be measured in a single run as a routine sample, as we consider within run. So we need to run all the levels at a time. And all IQC results should be systematically recorded. Of course, when you have a QC data management solution like Unity Real-Time, you don't have to bother about it. And then you perform at least 20 replicates of each HIL index on the corresponding frozen thawed IQC HIL aliquots in one run on the same day. So it means 20 days at least from 20 different runs. Then calculate the mean and standard deviation. I don't have to explain how it basically works. And then you have, you can confirm or you can fix the mean by having at least 50 consecutive runs. Then you can apply the Westergaard rules. And normally what Westergaard rules that we apply? The same kind of set of rules that we can also apply in the serum indices. Then monitor the performance by constructing the Levi-Jennings chart are comparable. That are comparable. Thaw another aliquot, if it is not working well, and again retest the IQC if that is failed. When the second IQC assessment is also not acceptable, then restart the regular testing. If the second one is not accepted, then stop using the HIL indices, investigate what could be the possible cause, do the proper troubleshooting, maybe instrument failure potentially, just look at it and then replace the automatic HIL indices assessment also with visual inspection if required, and then re-evaluate data previously, which is run. So this is the overview of a diagrammatic explanation of what I have just explained. I can look at it later. And then you also look at Unity real-time data, where we have plotted the data into a Levi-Jennings chart for all the different phenomena you can see from this. Then we also have the Unity interlaboratory comparison data, where you can look at for each level, how is your lab is performing and what are the variables. That means your mean and SD and CV percentage, and that is been established with how many number of data points. And when in comparison with the peer group or method group, how it is performing across, comparing across the worldwide participants. You also can see the distribution of the means and the mean that is established from the laboratory, and where is that lies when you have a group of labs that are contributed towards the mean, where you are exactly dispersed among them, that can be seen. And also the CV percentages, how much your CV percentage that you get and among the other laboratories. Are you with majority of the people, or are you better than them? You can definitely look at this report. And of course, we have like other recommendations and instructions for using IQC and EQUAS, etc. So same here for a pre-analytical also under ISO 15189 2012 4.9 talks about identification and control of non-conformities, so which is required. Again, 5.4.1 information for patients and use. You can go through the statements later also. Then comes to even from CLSI, we have C56A, which gives guidelines for a hemolysis and icterus, especially how the interference is supposed to be dealt with in a clinical laboratory practice. So there is one point: verification and quality control of hemolysis, icterus and lipema, turbidity, indices and alert indices in the clinical laboratory. So it talks about dealing with all these interferences and indices. Just to summarize the last slide, pre-analytical error, as we know that it's a costliest to the laboratory. So when specimens are rejected or results are inaccurately reported, we know what's going to happen. So having that confidence in the performance of the HIL workstation, it can help avoid costly investigations and instrument downtime. So something like serum indices would definitely help there. And laboratorians agree that monitoring the ability of the HIL workstation to detect interferences would add definitely a confidence to the adequate interference detection and to the laboratory personnel. Yeah, with that, I have come to the conclusion. This is my last slide. Thank you. Thanks for giving opportunity, ma'am, once again to Kaho. Thanks for listening, patient listening.